Hello, I'm Dr. Emily Tonorezos. I'm a general internist and director of the Office of Cancer Survivorship at the NCI. I'm very happy to be here with you today to talk about how NCI can help cancer survivors. I'm going to go ahead and share my screen. The Office of Cancer Survivorship was established in 1996 in recognition of the large number of individuals surviving cancer for long periods of time and their unique and poorly understood needs. In this photo, you see President Bill Clinton in 1996 signing the yellow ribbon of hope, and he's surrounded by cancer survivors, advocates, NCI staff, and family members. The office supports research that both examines and addresses the long and short-term physical, psychological, social, and economic effects of cancer and its treatment among pediatric and adult survivors of cancer and their families. Now, we use a definition of cancer survivor that says that you are a survivor from the time of diagnosis. And this definition really came out of the advocacy community and the National Coalition for Cancer Survivorship. And the desire with using the word survivor was to define the population and to move away from the term cancer victim. Now, I've said a few times that the definition of cancer survivor starts at the time of diagnosis. But as we know, a lot of cancer research in survivorship focuses on the post-treatment period. So although we have survivors in this entire section of time between diagnosis and treatment, we have a portfolio of research that focuses on the post-treatment survivor. So what we really need to do is move that arrow down to the time of diagnosis and think about the whole cancer continuum from the time of diagnosis through treatment and into a post-treatment stage for some patients and not for others. Now, this acknowledges a growing population of survivors who are living with advanced and metastatic cancer. And what you see on this slide is a graph of the growing number of women who are diagnosed with metastatic breast cancer and the growth in their survival, their length of survival, which results in larger and larger numbers of women every year from 1990 to 2020. Deb Mayer, who was my predecessor in the Office of Cancer Survivorship, took a look at these data and the changing landscape of survivorship, and also the fact that so much of our research in clinical care has focused on that post-treatment period, and worked to update our definition of cancer survivor. So this updated definition, again, it starts with the fact that an individual is considered a cancer survivor from the time of diagnosis through the balance of life. But it adds the fact that there are many types of survivors, including those living with cancer and those free of cancer. This term is meant to capture a population of those with a history of cancer, rather than to provide a label that may or may not resonate with individuals. And that last sentence is very important because there are many people with a history of a diagnosis of cancer who do not feel that the term survivor applies to them, or it doesn't resonate with them, or they just don't think it describes them or has anything to do with them. And what I want to emphasize is that even if you do not think that term applies to you, it's okay. But for the purposes of research, we really do need a way to describe this population. And so we have the word survivor, even though it's not a perfect term. If we can agree on a definition that says you don't need to be free of cancer to be considered a survivor, at least we hope to be more inclusive with that wording. Now, you may not realize this, but the NCI runs something called the Cancer Information Service. It's been around since 1975, and it's a 1-800 number, 1-800 for the number 4 and the word cancer. And the Cancer Information Service is a hotline that provides the latest, most accurate cancer information to patients, their families, the public, and health professionals. It also works outwards by disseminating NCI key messages and latest cancer information. And it interfaces directly with the public and responds to public inquiries. The CIS supports the Office of Cancer Survivorship in a few ways. First, it supports the research mission by educating the public about clinical trials and scientific discoveries. Second, it provides program and service delivery excellence. It's a way for the public to reach the NCI. And it also serves as a health communication laboratory. And what this means is that it's a way for NCI researchers and staff to get information about what the public is looking for. So when I first came to NCI just a short time ago, I went to the CIS and I asked them about this growing population of survivors with advanced or metastatic cancer, because I wanted to know what kind of calls were coming into the CIS related to survivors with advanced or metastatic cancer, so I could understand what kind of challenges were people facing and what were they looking to the NCI to help them figure out. So the first thing we heard is that people asked, where can I get a second opinion or find out about clinical trials? Number two, how do I talk to my provider about prognosis and treatment options? And this was a question that we heard actually not just from survivors, but from caregivers as well, who wanted to help their loved one have a conversation with their team about prognosis and what the treatment options were for advanced or metastatic cancer. Who can help me manage my late or long-term effects of treatment? I know that that question resonates with a lot of survivors who find themselves in settings, healthcare settings, where the providers just do not understand the late effects that they're experiencing or have no knowledge of the treatments that they've had in the past. So that is a big challenge, and the CIS is getting calls about that issue as well. And finally, they're getting calls around advanced or metastatic cancer and financial assistance. So what is NCI doing from a research perspective for advanced and metastatic cancer? After we went to CIS and we heard what patients and survivors and family members were calling CIS about, then we looked to the NIH supported research grants to see what are we funding that qualifies as survivorship research for those with advanced and metastatic cancer. So this can be a little tricky to explain, except I think survivors get it, but researchers sometimes have a problem understanding. But people living with advanced and metastatic cancer are facing many of the same issues that survivors who are free of cancer or finished with treatment are facing. These include things like care coordination, treatment-related toxicities, and surveillance scans or screening for secondary cancers. Those issues come up in this population as well. So we took a look at the funded grants from fiscal year 2020 to see what are we funding in survivorship research for this population. We excluded grants with a primary focus on end-of-life care, tumor progression or staging, and grants for which the only outcome was survival, which we considered those to be likely to be treatment-related studies. The results were a total of 25 active grants. 16 of these grants were funded by the NCI. The Nursing Institute funded 6 of them, and the Mental Health Institute funded 2 of them. The R01, which is the large mechanism, was the most common mechanism used, followed by the R21 and training grants. We had 1 U01 and 1 R03, and about half were funded through a specific funding announcement. So some of this research is coming to NCI in direct response to NCI requests, and about half of it is investigator initiated. A variety of cancer diagnoses were represented, including any cancer or any solid tumor. And interventional studies were more common than observational. Not surprisingly, the most common topic was palliative or supportive care for this population. We also saw some studies on psychosocial support, physiologic sequelae, physical activity, which was 3 studies, and combination physiologic and psychologic sequelae. There was 1 study on polypharmacy, and about a third included some work with a caregiver. Most had less than 6 months follow-up. After we conducted the portfolio analysis, we realized that we really needed to hear from stakeholders about their concerns and priorities and issues. So actually just a short time ago in early May of 2021, NCI hosted a virtual meeting on survivorship needs for individuals with advanced and metastatic cancers. This was a 2-day meeting with researchers, providers, survivors, and funders. It was open and free to anyone who wanted to join, and we had hundreds of participants. Speakers included advocates with advanced or metastatic cancer. We had an amazing panel, and our keynote speaker was Ryan Knipp, who's a GI oncologist who works and does research in advanced and metastatic cancer. Now, our goals for the meeting were to define the current state of metastatic and advanced cancer survivorship research, identify unmet needs among this population, discuss research gaps and opportunities in the areas of epidemiology, healthcare delivery, behavioral sciences, and symptom management. And these are just a couple of screenshots from our meeting. I just feel so proud and happy of what we were able to discuss. And over the next few months, the people who attended within the NCI are meeting to go over our notes from the meeting, talk about what we learned and what we think we should be doing in terms of next steps. Now, one of the reasons I wanted to go through this multiple avenues of investigation or stepwise progression in our activities is because I wanted to explain to you how NCI learns about a problem and ways that we move or try to move the field forward that aren't necessarily just funding grants. So for me, we have some research from the division showing that there is a growing population of people with metastatic and advanced cancer. And I showed you one example of that with Angela Mariotta's work in metastatic breast cancer. Then we have some calls coming into the CIS with questions related to advanced and metastatic cancer. Then we take a look at what is currently being funded, which turns out to be a very small number of studies, with the most common topic of palliative care, and with actually a large number supported in nursing and other institutes instead of at the NCI. So the next step then we say, well, we're not quite ready. We don't really know what the research questions are yet for this population. So we have what we heard from CIS, but let's try to get a broader picture. Let's hear from people working in the field, oncologists, researchers, psychologists, patient advocates, family members, people at NCI, people in other countries, and let's hear what they have to say about this population and the problems and challenges that they're experiencing. So that's how we ended up at this meeting. And the work isn't finished. So as I said, that over the next few months, we're meeting and talking about what our next steps are going to be from a funding perspective, or what other activities we want to embark upon. I wanted to give a second example of this kind of story, which is the STAR Act. So you may not know about the STAR Act unless you're in childhood cancer research or clinical care. But the STAR Act is the Childhood Cancer Survivorship Treatment, Access, and Research Act. And it was passed in 2018, and it authorizes enhancement to biospecimen collection and infrastructure, improvements to cancer registry infrastructure, and third, and most important for us, research to improve the care and quality of life for survivors. The STAR Act, I didn't leave a slide in here, but the STAR Act was the result of a tremendous amount of work on the part of the advocacy community and policy members and researchers as well. And it was years and years of effort went into getting this act passed. And it really was a watershed moment for childhood cancer research and childhood cancer survivorship research as well. One of the things that was funded through the STAR Act was work from AHRQ on barriers and disparities in pediatric cancer survivorship care. So the NCI, using the dollars from the STAR Act, commissioned AHRQ to provide an overview of the existing evidence and forthcoming research relevant to disparities and barriers for pediatric cancer survivorship care. They were to identify open questions, and offer concrete guidance research. Now, this technical brief came out just about 6 weeks ago. And so we went from funding to assessment to asking AHRQ to getting a technical brief in a very short period of time. What the technical brief told us is that there were a small number of studies on disparities, very few, even a smaller number of studies on barriers to care. And what I just want to say as an aside, what's interesting about pediatric cancer survivorship is that children in the United States, for the most part, not every child, but there is broader access to health insurance among children than among adults in the United States. And so there was something of a story in pediatric cancer that most children are being treated with some form of health insurance, whether private or public. And so as a result, the research in disparities and barriers for pediatric cancer care and survivorship care has really lagged behind our research in adult cancer barriers and disparities. And that was clearly demonstrated in this technical brief. All of the existing studies focused on the individual provider or survivor factors, such as knowledge or distance to cancer center. So if a child needs to come back for a scan, the farther away they are from the cancer center, the less likely they are to come back to the cancer center for the scan. But when you think about that problem, that is a problem of transportation. That's a problem that we're pretty well aware of in cancer survivorship healthcare delivery. What we don't have are studies of policy or organizational factors that contribute to barriers. So what are the things that are happening from an organizational perspective, the things we think of as structural or systemic? And there is no research on those types of factors. So what we did very quickly after the AHRQ report technical brief came out is we put together something for the cancer centers. And these are rapid funding and research mechanisms where the NCI can give small amounts of money, in this case, $150,000 for 1 year of research. And the idea with this particular supplement is to support research to understand and address organizational factors that contribute to disparities in outcomes among childhood cancer survivors. Cancer centers were encouraged to conduct observational studies or pilot interventions focused on understanding or addressing disparities in outcomes related to organizational, health system, or community level factors. So some of the things you might think about as organizational policies and procedures that contribute to disparities. One would be, for example, if you have to get a scan and a biopsy on 2 different days because of some organizational policy, you've created a barrier to the child being biopsied because you've required them to leave the cancer center and then come back on a different day for the biopsy. So that's something that the organization could look at and say, why are we losing our follow-up visits, or why are the follow-up visits not occurring? And think about the organizational reasons that that might be happening. This is a common practice within organizations. Usually it falls under the quality improvement or quality assurance type activities. For example, there is a huge effort to discharge patients early in the day from the hospital. And so over the period of several years, the hospital might undertake several investigations into why patients are being discharged late in the day and slowly implement interventions to try to move the discharge earlier and earlier. For example, if you have labs due on the morning that you're to be discharged from the hospital, let's make those stat labs so they come back right away. So we're not waiting for the lab in order to decide whether a patient can go home or not. So those are the kinds of things with childhood cancer that we really don't have any information about, but we know that there are disparities in long-term follow-up and survivorship care that are happening in this population. So we've asked the organizations, we've asked the cancer centers to come and give us some ideas for research that they could do to try to better understand these types of issues. One of the last NCI activities that I want to tell you about is really an investment in the future. So of course, NCI funds research. That's primarily one of the main and most keystone activities of the NCI. And one of the things that NCI did very recently in survivorship research is fund a series of cohort studies. So that's what I'm going to tell you about. So there was an RFA that came out, RF 20-030, which was to support prospective cohort studies that identify clinical, lifestyle, genomic, and other factors that affect health outcomes for cancer survivors. And the idea was to try to get some cohort studies to address gap areas such as emerging treatments, less common cancer sites or cancer diagnoses, and racial, ethnic, geographic, or socioeconomic disparities. And the way that this particular mechanism works is that you get a lot of money in the first 2 years, $750,000 in direct costs, but you have to set some milestones for recruitment and data collection. And at the end of those first 2 years of funding, you have to demonstrate the progress that you've made. You have to meet some pre-specified milestones in your cohort acquisition, and then you get approved for up to 4 years of subsequent funding. There were 3 studies that were funded through this RFA. The first is a study from Washington University in St. Louis, where they're focusing on one of those emerging therapies, immune checkpoint inhibitors. This is called the DIRECT study. And the aims are to investigate racial differences for African American and European American patients and predictors of immune-related adverse events, treatment patterns, and short and long-term outcomes. Number 2 is a study out of University of Miami called Avanzando Caminos. This is a cohort of 3,000 Hodgkin lymphoma survivors that will collect sociocultural, medical stress, psychosocial, lifestyle, biological symptom burden, health-related quality of life, and disease activity measures. I'm sorry, I said Hodgkin lymphoma. It's Hispanic, Latino, HL. Listen, where I come from, HL means Hodgkin lymphoma, but in this setting, it means Hispanic and Latino. So the idea is that with Avanzando Caminos is to get a Spanish-speaking cohort of cancer survivors. Finally, there's a third one that comes from Baylor College and Texas Children's, which is for childhood cancer survivors that are Spanish-speaking. And for this one also, they're looking specifically at treatment-related toxicities, chronic health conditions, patient-reported outcomes, neurocognitive, psychological, and functional outcomes. The last thing I wanted to do in answer to this question, how does NCI help cancer survivors, is to just tell you briefly about some resources. So first of all, as I mentioned at the beginning, I'm the director of the Office of Cancer Survivorship. And we started it started just before I got to NCI, but about a year ago to do a complete overhaul on the OCS website and to really try to grow it as a resource for for clinical care, for caregivers, and for researchers as well. So if you go to our website, you will find some information and some resources there. You heard me mention quite a few times the CIS 1-800-4-CANCER. There is also something called a PDQ, and it's called Physician Data Query, but it has a lot of information. It's at the NCI website, a lot of information on specific drugs or cancer treatments that can be useful. If you just want information about what drug is this, what category is it, what should I tell my provider about it, what should I be concerned about, those types of questions. And finally, if you're thinking that you would like to work further in this area, or you're feeling inspired and you want to make a contribution like some of the advocates that I spoke about earlier in the talk, please take a look at the NCI Advocacy Office. You can go to the website, you can email them at NCI Advocacy, or you can find them on Twitter as well. Thank you.